we're going to talk about comprehensive versus compromised treatment. And, I think it was really interesting. You sort of touched on this in the last episode that we were talking about, is sort of the question of liability of, when you are working with an outside party for treatment planning, for all of those things, who holds the liability on that, and what are the risks even of not having the depth of knowledge of diagnostic and treatment planning for ortho treatment?
It's not a problem until it's a problem. Well, I promise you, aligner places think, well, we've crossed our T's and dot our I's, and the dentist is thinking, hey, these guys I'm working with are real doctors, right? So it's, you figure that out in court, and everybody sues everybody. The good news with dentistry is we are blessed, is like financially, teeth aren't worth as much as the leg. Do you know what I mean? I mean, it's okay. It's serious though. It's why dental lawsuits aren't as prevalent as medical. It's the lawyers have to have money in it for them to sue, right? So, you could play the worst case. You don't know what you're doing, and you're putting excessive forces, and somebody ends up losing their teeth. Well, there's a value assigned with that, but it ain't in the millions. Do you know what I mean? And I think people wrongly, I don't worry about stuff like that, more worry about how do I sleep at night if I did something that some mom paid me to take care of this kid, that's her most important thing. I've got 4 most important things in my house, and that worries me way more than, am I going to get sued and how much is it going to cost? You know what I mean?
Yeah. I mean, when we treatment plan any work that we do in dentistry, we don't always follow that treatment plan. We often find that we're not able to follow that treatment plan. Things don't work out and we have to modify it, or we don't achieve the result that we wanted. All we can do is the best we can and do all that due diligence, and it's okay if you don't always bat 1,000. The problem that I see, in particularly in orthodontics, is that there's an obligation to meet the standard of care for your diagnosis. So you need to have this database that everybody that does competent work is going to have. Create a diagnosis that needs to be in the chart and a treatment plan that needs to be in the chart. And then you've got your documentation and you've done due diligence, you've met the standard of care. And then there's the obligation to discuss that with the patient. So now we're going to have a conversation about comprehensive treatment and our goals and objectives, what we're trying to achieve, and the reasons for it. I'm trying to go over that stuff with the patient. And, likewise, if I'm treatment planning a compromise, I'm obliged to discuss the impact of that compromise so that they can make a decision, about the advantages and disadvantages of that. There's not a lot of risk in liability if you have got a good diagnosis, you've got a good treatment plan, and you have made a good faith effort to give them informed consent, that they know what they're getting into. Like a denture. I always tell my patients when they're thinking seriously about, kissing all their teeth goodbye and going into a denture, that when you cross that bridge you burn it, kind of thing. And these are the percentages, and I start telling them, the 2 worst teeth in your head are going to chew better than the best denture I can make you, and you're not going to taste food the same, and you may not be able to it may gag you. You just may not be able to tolerate this thing. And then what are you going to do? And I'm going to go over all of that with them. Then if they still want me to take all their teeth out and make them denture, then I'll go there. But we just have that obligation to make sure it's an ethical thing, it's a moral thing. It's
why I always thought it was funny, but you take ethics classes, and to me, it's like, do you have a soul? Like in my head, ethics is like a built-in part of the software. And if you don't have it, taking it, I mean, now the legal part of it, sure.
Hey, it's estimated 20% of the population are literal sociopaths. So
Yeah.
1 out of 5 people that you meet.
Why are you staring at me? When you say compromised treatment, are you talking like compromised treatment from the get-go, meaning, hey, this would be ideal? I know that you don't want this and this much of a commitment. We're going to do this. Are you talking you're in the middle of a case and you're going, it ain't going to turn out like I thought it was? Compromise.
So I think there's actually two aspects of compromise that I sort of was thinking of. One was compromise in terms of your involvement in the case, your level of understanding of treatment, that kind of thing. And the other is, this is kind of the ideal treatment plan, but that's not really what the patient is asking for. Is it okay to do X? So it's kind of two different.
Some of my favorite cases that I've done orthodontically are the most whiskey tango
Foxtrot.
cases, and it's literally like on a 70-year-old who's got a lateral in his palate that he's had, and it's, you're probing and you're just going, why don't we just take that out and like see if we can move these teeth and close this and reshape teeth? And it's like, but it was a complete compromise case, and it made sense to him, and it was like, and it looks freaking fantastic. I guarantee you, no one he talks to besides the dentist is going to go, what happened to his lateral? Because he's got, teeth aren't perfect, and he freaking loves it. It's like, these are sometimes, just using just common sense. What could we do here? The problem with that though is, the guys I work with are like, oh, you can just do this, this, and this. I'm like, what planet are you on? You can't do that. It's like, but in their head, they think they can do it.
Well, they think they can take hit from the bone.
One thing I do want to touch on a little bit, because you did mention this in the last podcast, and that is, we've had a number of doctors reach out to us who have had their dental board basically prevent them from performing orthodontic care because of someone made a complaint and they didn't have standard of care records. They didn't have those types of things. And just talk a little, if you don't mind, on sort of what's sort of the basic expectation of that, and what risks you take of not having those.
Yeah, records are always going to be like, it always comes down to records. We need those for defensive legal purposes, but we also need quality of records so that way we can make proper diagnosis. I mean, and everything, no matter what you're doing in the industry, stems from a proper diagnosis. And but it mentioned earlier about wanting to take pride in your records. When somebody and I had to get it across to my girls this way. It's just like, because I got asked a question once, well, why do you need this and all that stuff, as far as like, the pictures to be exactly cropped this way and all that stuff. It just seems to be micromanaging. I'm like, no, listen, we want to hold ourselves to a high standard of care. What if this patient, I'm not even thinking board complaint or anything, what if this patient moves?
Yep.
We are much more of a transient time in history than ever. People don't stay at the same job for 20, 30, 40 years like they used to. People move. And so it's like, what if they get transferred, or what if they move and we need to send these? Do we want to be sending shoddy records and things that just make it look like, this office is janky? Or do we want to have something that people are like, wow, they took some care into doing this? And if you took care in your records, then more than likely you're going to take care into other aspects of your treatment as well.
It's what I label the, not trying to cuss, give a shit.
Yeah.
It's when we make our temporaries, you'll think this is funny. When we do our own CAD CAM, but if we're making a temporary, it always goes to the pumice wheel. Why? Because if this person this weekend and it comes off and I'm not there, and another dentist, I always joke, I go, I want him to feel bad about how he's temporized. I want him to look and go, holy crap, this is a temporary? you know what I mean? It's like, now I don't get there every time, right? But that's what you should be shooting for.
Yeah.
It's if you can't take, that's one thing you can do, even if you're, that's one of my old instructors. You say, if you can't make it right, make it bright, you know. But if you can't take the time to take stamped records, and that's your shooting for that, then you know girls will miss photos. We still take pictures every freaking visit, because that's how I learned with you guys. And I don't have to be in there as much. I can sit there, but when I get free time, I can just click through months, what's going on here? What have we been checking with? Oh crap. It helps me, to me, I think it saves time, and it's not even my time, it's their time, and they've gotten so damn fast with it. It's all in Dolphin, it's easy. But it's like, if you're not going to hold yourself to that, then don't get into ortho. Yeah. It's just a bad idea.
I think that, you know, what you're saying about us being so nomadic and everybody's all moving all the time, and ortho is a tough thing, you know, to deal with whenever you've got patients moving in and out. But I'm always pissed that I never get the records I request whenever I've got a case
They don't
coming
want to
in.
send them to you.
I know, and when I get a request, I get happy, you know, and I
Like, check this out.
yeah, exactly. Because I had this orthodontist, request records, and I sent him all of it and a PowerPoint that showed the case all the way up to, you know, the thing is that if I had gotten something like that, I'd like, okay, I can see where he's going with this, instead of, and maybe even consider continuing to try to do what that guy was doing. Right. But most of the time, orthodontists are, you know, they're like, well, I'm not going to do it. You know, I don't know what he was doing, but I'm not doing it that way, and he's going to go a completely different direction. There's no coordination of that treatment at all, and with no better records than I ever get on a case that transfers in, I certainly don't have a clue, you know, where he was going or what he's doing. I do have to kind of start from scratch, and that's just, it's not good for our patient. But moreover, if you send an orthodontist a set of records, and odds are, you know, there's only 6% of us that are doing fixed appliances that aren't orthodontists. So they're probably going to transfer to an orthodontist. Mm-hmm. And if they get your records and they're crap, you know, like cow patty, stone models and photos you shot on your, then what's he going to do? He's going to say, this clown is a joke. You know, you should probably get your money back. They can throw you under the bus in a hurry, right? It would come very naturally for them to just toss you right under the bus. But if you send them pristine records and you've got this really nice treatment plan, they're going to be, if anything, intimidated by that, and they're like, yeah, well, he looks like he was doing a good job, you know.
I would say doing orthodontics without records would be like doing an endo without a PA.
Yeah.
I mean, you know what I mean? Yeah. How do you know?
Yeah.
How do you know? Pre and post, right?
Mm-hmm.
Yeah.
So talk a little bit about, you know, somebody mentioned before that, you know, when a patient comes in, they have their realm of knowledge of and understanding of their concern, whatever, and what the possible treatment may be. How far do you kind of, you know, they say this one front tooth is whatever, and you just sort of like, okay, well, we can fix that, versus going into, well, also your molars are, you know, out of occlusion and whatever.
So I'll just say I try to keep it. What Einstein say? It's make things as simple as possible, but no further, or something like that. And just like we want to make it simple, but we don't want to dumb it down too much. I always give people at least two options of things. You know, I want to hear about what their concerns are and what their goals are. And then I can usually fit at least one or two plans into that goal. But like, for example, with adult, you know, orthodontics and everything, you know, I'll tell them like, okay, their concern is this tooth. It's like, okay, there are two ways that we can go about this. A little bit more of a cosmetically driven plan versus more of a total comprehensive plan. Because a total comprehensive plan, I see this tooth is super erupted because this tooth is missing. So if you ever wanted an implant with this tooth, well, we need to get that guy back in its space. Create the room for the tooth on that implant. You know, I can get into airway, all this stuff. So I can very easily come up, you know, talk about a comprehensive treatment plan. But then I ask, but if those aren't your goals and we only want to focus on this, then I can do this with brackets or aligners. It'll take about a year, and but we're not going to be addressing this other stuff. And I don't think there's any problem with that. But you have to be able to really talk to them about it. Just like, if somebody's a half step or quarter step class 2 and, they're wanting 6-month braces or something like that, you have to let them know, okay, yeah, we can get these teeth straight in the front. But you know how your teeth, or if they're class 2 div 2 and they're like this, well, you know how those teeth touch? When I round out this arch, they're not going to touch anymore. And you're going to have what's called overjet. And so you need to be okay with that. And so it's just, to me, that's what the kind of informed consent. But I think as a profession, a lot of us make our informed consents a little bit too technical. And I'm okay with it being technical on a sheet of paper. But when we communicate with patients, we
Agreed.
need to talk to them in layman's terms and terms that they can understand. It's just like you said, when you have your team members start work for you and they're fresh off the street and they're ignorant, they don't know anything.
Yep.
And so we forget, because we live in this world every day, we forget how ignorant people are to dentistry. And so we need to be able to talk to them, because it makes me wonder, how can we truly get informed consent with how little knowledge people
That's a good
have
point.
as far as dentistry goes? But when we converse to them, we don't need to be talking about irreversible pulpitis. We don't talking about root resorptions in those terms. We still need to convey those possibilities, but in a way that people can understand.
Yeah, it's just like occlusion. We got occlusion out of the way in dental school really early in the process, and we were taught all the reasons why that occlusion needed to be the way it was and all the consequences of problems it was going to generate over time if we didn't have a good occlusion. And it's like all of a sudden you are asked to check all that at the door and forget about it, and we're just going to straighten up these front teeth and call it a day. I think that we're obligated, to somehow convey the consequences of leaving that malocclusion there and what impact it may have on their health long term. They're entitled to know that. And I don't think we have to explain, occlusion to them, but we can talk about attrition, we can talk about joint dysfunction, we can talk about all those kind of fractions and all that stuff. And yeah, you can just call them those little notches on the gum line and all that. But all of those things are important, and that should be on the table so they can make a really informed decision about which of those two options that they're going to go with. And then as long as they know that I'm going to feel okay with, even whenever I'm trying for a comprehensive result, I don't always get there. Yep. I tell them that we may not get there. There's nothing more disheartening than doing, a case and you've been treating for 2 years and you end up with a quarter step class 2 on one side. It just will not stay distal enough, and you just can't get it socked into an ideal Andrews class 1 occlusion. And you feel bad, but you're looking at this kid and they're not going to do this anymore. They're not brushing, they're not wearing rubber bands, they checked out. And so you're like, I'm going to hurt them more than I'm going to help them. I'm going to have to bail. So I missed the mark. I got a C. Didn't get an A on that one. It's going to happen. But I feel like that left to my choice, I will always want to treat to ideal, and then for whatever reasons and factors enter in, then we can start backing away from ideal.
That's where you have to start.
Yeah.
I always thought that, to me, if I was running a dental school, you would have a class, multiple semester classes on communication, like what you're talking about. And it literally, you'd have to how you had to check boxes? It's like, all right, you're going to explain, here's the x-ray, you're going to explain root canal. Mm-hmm. And just to the normal person.
Right.
Right? And to where focus makes somebody think about, where is this person's level of knowledge coming from? And it's like, I always start with the cupcake. Here's the cupcake. Outer layer of icing is your enamel, right? And literally, that's literally what I say. But because I think when I have buddies of mine that are 10 times smarter than me that struggle, and it's just communication. Mm-hmm. It's that explaining it. I don't want to say dumbing it down, but putting it in terms that someone can understand it. That's actually funny you say that, because you think about it, and it is. Like, how do you give informed consent to somebody who doesn't know what you're really talking about? But anyway.
No, it's really.
They should be having that.
Yeah, it's an art.
They used to do it at UMKC with perio. You had to be able to explain, gum disease and stuff. But then they cut it, and so that was all taken out. But it's like probably one of the most important. If you're going to label a good dentist, characteristics. Communication. Like overall success of your practice, your career.
There's a lot of crappy dentists out there that are killing it because they're good communicators.
And there are a lot of fantastic dentists who are struggling because they can't.
Yeah.
Agreed, man. 100% agreed.
Work. If you needed, a crown or a class 2, you'd want to go to them. They're going to use the rubber dam. They're going to use everything.
Yep.
But their communication skills are in the toilet. So.
Not everybody can have what we have. I'm kidding. I wish, right?
Yeah. Sitting up tall,
I felt like, though, when you did say there was like dentists that have good communication skills but hand skills are crap, I felt like you were talking about me.
I was looking at you.
You were, you were kind of looking at me. Why, did you see something?
Well, thanks for the conversation and for being on the podcast. I appreciate
It's
having
fun.
all
Thank
of
you
you
very
here.
much.
Fun.
Yeah.
Thank you.
My pleasure.